Thank you so much for having me, and literally looking a little windblown because I ran here. So I just wanted to talk to you today about the pathway to accreditation, HPB surgery. And the older I get, the less data I have and the more opinions I have. So forgive me for the lack of data. But first of all, I have some disclosures in that I'm a consultant for these three companies. I'm open to any more if anyone wants to offer me anything. So this is just the brief outline of my talk, my personal story, because I do think it's important to know where I'm coming from, why accreditation is important, the mechanisms available to gain accreditation, and kind of where we go from now. So first of all, this is my timeline. I was in sort of a traditional academic pathway, and then, you look at this 2005, and I fell from grace. And I'm here not only to talk about the perspective of somebody who does high volume stuff, but also to give everyone hope that this can be done outside of traditional structure. And I think as time is going on, academic, non-academic, we're all blending, and so we need to learn from each other. And I'm here to provide that perspective. So I actually feel like I'm a little bit more academic than I was in, quote, academics. And I sort of think about this, even though I'm in private practice, as three legs to the stool. And, my whole thing is inclusion. It's the DIE, or the DEI part of it, the inclusion part. We should all be inclusive and learn from each other, whatever areas we come from. And these are the three legs that keep the stool up in whatever environment you're in. And so I've tried to build this outside of traditional academic medicine. And it's just the three of us. You might think we're the UN, but we actually are a very great group of colleagues that I work with, both trained under me and have joined me, and so blessed to have a great group to work with. So why is accreditation important? As shown in this amazing MRCP with the right posterior sectoral duct that's completely transected, we've got these three high areas of surgery, and I'm in no way discounting rectal because it's so amazing, and other esophagus, etc. And actually, I'm sort of an old-fashioned general surgeon because I still do other GI cases, including esophagectomy. So just some personal data. Our average sort of mortality for Whipple is around 2%. Trisection, not a very commonly done operation, but it carries a pretty high mortality, especially if combined with a biliary anastomosis, bile duct injury. And then, these are length of stays. And I put this slide up because compared to, say, a robotic sigmoid, which can go home the next day or the day after, which is amazing to me, having grown up in the open era, these cases still stay in the hospital for a while. And so the system becomes important. And I put this slide together because I got this from our administrators that our program being present led to a 20% growth in volume in these areas. So the program matters. And as you heard from Dr. Aschlanger, the volume outcome relationship is especially real in things like esophagus and pancreas. And so we know that the longer the stay in the hospital, the greater the effect of the system. Because, you could do the best operation and you could sit at the bedside all the time, but if you don't have rescue by IR, if you don't have radiology services, that's not going to work. Whereas something that's purely technical, like carotid endarterectomy that goes home the same day or the next day, can be transferred. But we've actually shown, and this is a busy slide, but focus on this, that when we moved to a new hospital that had never done any of these cases, you can actually transfer expertise. So the surgeon can drive this, and I use this argument to say that we should help each other to be safer. We must be good to begin with. It is good to have standardization. And really, the next part of this talk is really how to prove that your program is important to the system that you're working with, and how they should look at accreditation as being beneficial to them. And also, how can we help others build a program, right? I don't want my patients to travel 6 hours in a bus yellow arriving at my doorstep, I want to help somebody to help them closer to them. And I can be the rescue, right? That's fine. Please send me, the disasters. So these are the two accreditation programs that are available right now. One is through JCO, interestingly, and one is through the ACS. And let me walk you through this. So JCO actually has a disease-specific accreditation process. Nobody really knows this outside of joint and stroke, but you could actually write it. So we did. And we were the first in the country to be accredited in pancreatic cancer. And then at my sister institution that I've just moved to about 5 years ago, we chose HPB surgery. Now remember, JCO is focused on nursing. Your survey is going to be done by an RN. So I always say it's like the land of Oz. You choose the speak that you're going to talk in. Onco speak, gastro speak, nurse speak. Don't talk in Dr. Lang language. Think about what the nurses are looking for. So they're looking at where the physical therapy notes are, when is pain management being dealt with, etc. And they wanted 4 quality measures, and these were 4 things that we chose. Quality of life measure, a nutrition counseling in all of our patients pre-op, managing pain, and timeliness of care. Believe it or not, we chose 3 weeks from the time that they touch our institution to first course of treatment. We borrowed this from the UK, where they use 4 weeks. Now, this sounds ridiculous that it takes 3 weeks to get somebody to the operating room or to chemotherapy. Believe it or not, that's shockingly quick. And we were the first in the nation to get this. So this is the group. It was amazing. It drew everyone together. Just the ACS high-risk GI program. So this was a program that was started by David Hoyt, and I actually was really proud to represent SAGES in the area of liver. And as you can tell, I was the person around the table that was like, why are we doing this? Why is this? Why do we just consider, quote, the ivory tower academic programs to be the high-volume programs? They do exist outside also. And they chose 4 sites, which was liver, pancreas, esophagus, and because Fabrizio Michelasi, who trained me, was on it, IBD. And we were the first site as a pilot program, which was terrifying, especially since it was by Zoom in August of last year. And to boot, David Hoyt was our site reviewer. Get this, going over all of my complications with David Hoyt, and I'm sitting there saying, I really probably shouldn't have done this esophagectomy on this patient. And he goes, is the patient alive? Yes, but she had a prolonged course. She goes, oh no, don't worry about that. You did the right thing. And I'm like, David Hoyt is comforting me. This is crazy. So it was a pretty cool time. And just to show you our volumes, I just want to point out just exactly, the kind of volumes that we have even in a little program like us, 76 biliary cases, 40 esophageal cases, 129 pancreas cases. And we're a 200-bed hospital on the north side of Dallas. And again, these are just some abstracted to date cancer cases at our site. So, and just to talk about distances, Brent mentioned this, but the South and the Midwest are just, it's so far to get anywhere. So we get people from Oklahoma, from Arkansas, from Louisiana, etc., coming in and, for their care. So what have we learned over this time period? Well, first of all, I think we've taught others a little bit about what a community program looks like. I think David and Fabrizio left thinking, wow, this can really happen outside of a university classic program. And verification has made us better. We've tried to make the best of an academic program in the community, but I always say sometimes it's easier to change the course of a yacht than the Titanic. Because literally changing the order set, where in the academic institutions I've been at, has been so challenging, whereas here it goes boom, boom, done. And so that can be nice, but you've got to drag everyone with you. Sometimes you feel very lonely because you're the only one, as opposed to having all of these peers that are going the same way. We also have fellowship programs, and this was just vision, just trying to push it yourself. Students setting up programs. We partnered with the osteopathic school because they wanted sites. And we have an academic feel, even in a private program, which has been really great. But I really do think that the preparation for the survey was great. We got all of our separate groups together. We physically had to stop and take stock of the program and figured out what we did well and what we did poorly and make it better. And we had these different private groups. When you're in private practice, you're not all under the same plan, so that makes things really challenging to get everyone on the same page. And you have to figure out how it's going to affect people financially. So we were compliant in all areas, and these are just a few things that actually the survey gained us. We were able to get more staff. We increased our tumor board frequency. We've documented more pathways, and we're looking at a geriatric pathway. And we also realized that we need to recruit from not just surgery, but from other tracks like oncology and GI. So we did get the verification. They just called it verification, not certification as yet, even though I'm begging them to change that. And it was an amazing process. So I just want to thank you all in this very quick rundown and a very sort of a lot of slides to go through in a short period of time, but I just wanted to excite you and energize you about the fact that this shouldn't be punitive. This should all be making us better. I believe that volume can be done in any environment, and also that there are people that perform low volume of a specific kind of surgery but do it really well, and we should be there to help them. Thank you so much.